Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Thanks, Doc. And we're also joined by Lieutenant Charles Bustos, my classmate from the 69th Cadet class. There's a lot of 76 information going out about there, but we're still going to represent the 69th. So I appreciate you being here.
I appreciate you, Chief. Thank you for having me. Thank you, Doc.
A lot of great calls, a lot of great experience. You've spent a lot of time up here in the training academy helping out with our refreshers to talk about interesting cases and just giving your perspective. So I always appreciate that. And this was a great one that I think is really relevant to a lot of providers and something that we're encountering more and more. This was a call related to a bleeding fistula. You were assigned to Rescue 20, and you all were dispatched to a 21 Delta severe hemorrhage at a skilled nursing facility. It sounds like the information that you got was that he was bleeding from his shunt, and you guys were the first arriving units on scene. So some good information there. It kind of helps you paint a mental picture, but I know that especially in 20s specifically, you guys work with a lot of skilled nursing facilities. So tell us some of the things you're thinking about in terms of interactions and what you're anticipating when you get there.
This facility, we were just more concerned of where the patient was at, what's going on. We're just trying to understand how severe it was. We've seen some fistula bleeding before, so we know how serious it can get. So our first thing is we walked in to the facility, and they moved us to the center corridor. He was out in the open area. He was in a wheelchair. They said that the patient had just been brought back from dialysis treatment. And when the nurse was taking him to his room, she noticed that he was still bleeding from his bandaging. So when she went to readdress that, she opened it up. She was going to rebandage it, and it started spurting. She tried to cover it, called for help. By that time, it was just out of control. They called for us, and we were there right away. But it was a pretty extreme bleed.
So typically something they can handle if it's a small bleed, but obviously by the time you got there, it was pretty extensive. Talk to us about how much blood did you see either on the floor, on the patient, or on the other providers?
As we walked outside into the main area, there's staff. They probably had about 5 or 6 people trying to address the situation. The main nurse, her shirt was covered in blood. There was 2 small towels on the floor that were saturated. The patient was not, I wouldn't say combative, I would say non-compliant. He was in a lot of pain. He was panicked. He was moving around. They were trying to apply a tourniquet at that point, and he was yelling, just a lot of movement, so it was just continuing to bleed.
Made it difficult, yeah, and causing more bleeding, I'm
Yes.
assuming, yeah. Doc, talk with us a little bit about AV fistulas. What are they and how do they work?
So these bleeding dialysis fistulas, they're actually a graft that's done by a vascular surgeon for access for dialysis. And in these patients, their kidneys aren't working, so their blood isn't being filtered. And so they need to be hooked up to a machine that can filter their blood for them and do the job of the kidneys. And in this instance, they physically attach a vein to an artery, so the blood flow is mixed, arterial and venous, and that helps with easier access. It's been a good step forward in modern medical treatment because these patients used to have to have indwelling catheters that were set up for infection. But some of the risks of these fistulas is that over time, as they're accessed more and more, you can develop an aneurysm or thinning of the vessel walls, especially with these veins whose walls are thin to start with and they're under arterial pressures, especially, and we know most of our dialysis patients tend to have very high blood pressures. And sometimes these venous walls are not meant to withstand those pressures, so they are at risk of bleeding and sometimes can be very severe.
And with that thinning of those walls, sometimes those repeated needle punctures can exacerbate that.
Yes, weaken the walls, especially if they're accessed repeatedly in the same spot. Essentially, it's creating a hole in the dike, and it's just waiting to go.
Absolutely. Okay. So back to the scene, we have the staff who's attempting to place a tourniquet. You guys are there now and ready to take over. Tell us about what your first steps were and how you addressed the patient.
My first I wanted to see if the patient was on blood thinners or how soon they left dialysis, just to see. And that's when they were saying he just returned. So I knew he was going to have anticoagulants on board as well. So that was my other concern of we need to address this. This is a lot of blood. We need to act fast. We took over. I let the firefighter from the ladder, he started taking care of the tourniquet. This was a position to where he was still moving. We had to secure his arm. I asked him to hold his arm out to the side more because the fistula was actually in a higher position. So it wasn't where we see him lower, this was actually making it difficult to set the tourniquet in the right place. So once he was doing that, he's a newer guy, real aggressive, did a great job, but he was still concerned of how much he was having to turn and how much the patient is screaming, how much pain he's in. And I'm like, do you have a pulse? He's like, yes. I'm like, we need to go again. I'm sorry. We need to stop the bleeding. And it's like, okay, I'm like, one more time. And he's like, and he did it. Great job. We got the bleeding. AS pulled up. And I was like, we need to go.
Nice. Okay. And that's probably one of the hardest things for us as providers, right, with the tourniquets, is we feel like, are we doing more harm than good? But you did a great job by talking him through that. Like, we need to make sure that there's no pulse present so we know that blood flow stops and then the blood stops coming from the site. Like, it's a fantastic job. Doc, thoughts on that?
I totally agree. I love your approach to this patient. It's essentially trauma at this point. It's uncontrollable hemorrhage, and quickly recognize the need to move to a tourniquet. And it is hard when your patient's telling you that it hurts and they're asking you to stop, but you know this is what's going to save their life. Yes. And you can, once you stop the bleeding, you can address the pain later, but you've got to stop the bleeding first. And I'm glad you stuck to your guns there and correctly evaluated the tourniquet to make sure there was no distal pulse and that the bleeding had slowed.
And a great thought process, I think, on the fact that knowing they're going to get heparin, right, when they go to their dialysis treatment, they're going to get the blood thinners right off the bat. Uremia can also exacerbate that as well, right?
Yes, it actually, great point, and that's great that you were thinking about that, because dialysis patients in particular, as their blood is cycled through these machines, it essentially functionally inactivates their platelets. It makes the platelets less sticky, so they're prone to bleeding due to their platelet level may be normal, but their platelets aren't as functional. They're also given heparin as their blood is taken outside of their body and circulated through a machine. And then the uremia is a chemical in the blood that builds up in renal failure and can also make the blood more prone to bleeding and not clotting. So all of these factors add up to make this type of hemorrhage very serious and needing aggressive treatment.
So now the bleeding stopped. We're getting ready to transport. Did we assist in the transport?
We did. We rode in. I took Ty, the firefighter. I asked him to ride in as well to keep control of the arm. I want you to secure that arm, keep it in place the whole time. We initiated. AAS attempted an IV before we left. It was unsuccessful. I said, let's just go. I got the IV en route, and we pushed fentanyl.
Did that help him feel better?
It took 2 doses. But by the second dose, the first dose, and I was like, well, we got another repeat set of vitals. And then the second dose actually was where he was trying to stop reaching for his arm and stop fighting us so much.
Good.
In terms of fluid replacement, how much did you guys end up giving him during your transport?
He got about 800 by the time we got to the hospital.
Nice. Vital signs they maintained stable vital signs.
They maintained stable. He was still, the whole time he stayed a little bradycardic, but he was hypertensive the whole time.
And what was you got the pain medication on board, which absolutely I'm sure helped. By the time you guys arrived at the hospital, is his presentation similar, still a little bit combative, agitated, or had he calmed down?
He had calmed down quite a bit. He was still in pain. It didn't knock it all the way out, but he was more compliant, and he wasn't reaching to move his arm around or reach for the tourniquet anymore.
Awesome work. So some new developments out of Europe, something they're using out there. Talk to us a little bit, Doc, about how they're approaching these patients with fistulas.
Yeah, as I was reading about this emergency, and I personally have also had a difficult approach to a patient with this type of bleeding that's very serious and scary. There is a new thing. It's very common in Europe now. I think it's starting to catch on in the United States, but it's essentially taking a bottle cap off of a water bottle or a Coke bottle, anything about the size of a quarter, to put over the site that's bleeding. And it's just the right diameter to catch both the artery and the vein and do the direct pressure there. And it's to the point in Europe where when they start dialysis, they're giving these patients their own bottle cap on a keychain so that they can control their own bleeding if this happens until EMS gets there. And I thought, really neat concept. I don't know if it's ready for our guidelines yet, but if you happen to find yourself in this situation with, without a tourniquet or with maybe a family member, it's a nice stopgap idea for a way to apply direct pressure to bleeding without having to be too invasive or cause a lot
I read
of
that.
pain.
That's a great study, everything about it. I think my first thought was, in theory, that sounds great. But I remember the scene, and I was like, a bottle cap is it? But I think early onset, if it's caught right away, I think that's a great thing to have.
Yeah, for the more minor bleeding, I think it's a nice idea. This patient sounds like he definitely was at the tourniquet point here. But.
You did a fantastic job. I think we talked about your approach to it was spot on. They had already tried the direct pressure on it. That wasn't going to work. And then you focused on the upstream to get that tourniquet placed. I think that's truly what saved his life. I think some providers may be worried about, like, how do I place that? Because the tourniquet cause damage to the fistula, but I think our thought process is always life over limb, right? He's bleeding out essentially right in front of you. So you guys made the absolute right call by sticking with that tourniquet and then talking the firefighter through to make sure it was placed appropriately. So good job. Obviously, super senior rescue lieutenant, this is a fantastic call that you painted a great picture on, but any words of wisdom that you would provide or give to new providers if they encountered a call similarly to this?
I would just say don't hesitate. Just if there's a reason, we have a lot of training, great training provided here. There's a lot of things that are in our head already, and subconscious, whatever it is, and trust your instincts and go with it. There's a reason you're thinking that thought process. Consider everything you can en route, and whatever you see, when it's that bad, treat it as aggressive as you can, and then make adjustments as you go.
Great job. Great call, great report. I know you're a guru on documentation. You've taught a lot of our providers about appropriate and proper documentation, so I thank you.
Thank you.
And thank you for coming out to talk about this call. I think it was great.
I appreciate you guys having me.
Absolutely. So that's it for today's case. If you have any interesting cases you want to bring, use the SharePoint tab or reach out to anybody in the EMS cadre. Come down, talk with us about it. And until then, we'll see you next time. Thank you.